Hi, my name is Connie McPartners and you're watching the video on the Synoptophore. This is the first video in a series of videos where we'll discuss the Synoptophore. We'll start off with talking about the instrument itself and its principles, and then move on to how we set up a patient on the Synoptophore, how we investigate a patient's binocular single vision on the Synoptophore, and then also how to go about interpreting the results from a Synoptophore. Let's start off talking about the instrument. So the Synoptophore also is termed a major amblyoscope. I'll be referring to it as a Synoptophore, but various textbooks will list it as the major amblyoscope. And it's able to assess the patient's BSV and give us information about their potential to have BSV. So just as the test we talked about earlier, the Prism Subjective, for instance, this test can also simulate photophobia and tell us whether the patient has capacity to have a positive post-op outcome with binocular single vision, as an example. This instrument is also able to assess separately each component of the 3 grades of binocular single vision. So we can start off by assessing simultaneous perception, we then move on to assessing a patient's fusion, and then to stereopsis. And as part of the simultaneous perception assessment, we're able to gain information about the size of the deviation. We can gain information about whether the patient has normal retinal correspondence or abnormal retinal correspondence. And we're also able to map a suppression scotoma should a suppression scotoma be present. Another use of the Synoptophore is that it can be used as part of orthoptic treatment. It's not commonly used as part of orthoptic treatment in Australia because it does require that your patient come into clinic for treatment, and we usually prescribe treatment that can be undertaken at home rather than coming into the clinic. Okay, let's take a look at this instrument. It's a haploscope. What it allows us to do is to present one image to one eye and another image to the other eye. Just like when we're performing Bagley striated glasses, where we show one line in one direction and another line in another direction, one at 135 and the other at 45. Again, with this, we're trying to see what will the patient do when we present different images to each eye. And we do this using slides, and here is the slide holder. And here is a pair of slides as an example, where one slide has the image of a lion, and then another slide has an image of a cage. So if I put this line in this slide holder here, this would be seen by the right eye and the cage would be seen by the left eye. What we're seeing, just to clarify also, is the examiner's view. So you would be standing in front of the Synoptophore here in control of these dials. The patient would be sitting on the other side and their forehead would be sitting up against this forehead rest, and the chin will be on this chin rest here. And they'll be looking through these tubes, the right eye through this tube, the left eye through this tube, and the slide here of the lion will be projected into the patient's eyes through a mirror that's placed within that tube. Okay, now in order for the patient to see the images of the slides, we need to turn the instrument on, which allows the light bulbs, which are in here, to illuminate those slides. Not only that, but the light that emanates will also allow us to see the corneal reflections of the patient so that we can objectively observe those corneal reflections, utilise them to set up the patient in terms of their interpupillary distance, so the IPD. And the reason we do this is because with these tubes here, we can move them closer together or further apart so that we can account for the patient's IPD as they're on this instrument. To move the tubes to account for IPD, we rotate this lever here and this adjusts the patient's IPD. I'll come back to this in a video a bit later on. We're also able to lock the tubes. So here is a lever here. If you rotate it, it will lock this tube here so it's unable to move. And again, if you lock this one here, this will be unable to move. Now, the reason why we want to lock a tube is because we want to assess the patient fixing right or fixing left. So just as, for instance, with the prism cover test, we might measure the deviation with the prism in front of the right eye. In that instance, we're fixing left. So if you want to do a fixing left assessment on the Synoptophore, then you would lock the left tube and allow freedom to move the right tube. Okay, we can move this tube in various directions. With this lever here, the horizontal deviation lever, so there's one on each side, we can move this forwards and backwards to measure a horizontal deviation. And so by moving it forwards or backwards, we'll move the image, let's say it's the lion, along the horizontal plane. Okay, what if the patient has a vertical deviation and we want to move the image along the vertical plane? So we want to move the line, for instance, up or down. Well, we have this vertical deviation control just here, one for the left and one for the right, and it will move that slide up and down, and depending on what you need, you can determine whether you need to move it up or down. If the patient has torsion and the image is tilted and you want to bring the image back upright, then we also have a torsion control just here. This is the torsion control here for the right, and here it is for the left. Okay, so the Synoptophore is one other test that can measure torsion. So far we've learnt about the Maddox swing, which can look at torsion. We know that the Maddox rod, or specifically the double Maddox rod test, can measure torsion. And another test is the Synoptophore. We'll talk more about that next semester, and we'll introduce a few other tests that can measure torsion next semester as well. Okay, we also have here fusion vergence control. So this here makes the tubes converge and diverge, which will force your patient to converge and diverge. And so it allows you to measure fusional convergence and fusional divergence. When you're assessing fusional vergences with the Synoptophore, you need to ensure that the central lock is on. Can't really see it very well here, but there's a central lock here that you'll become familiar with once you move into the prac room. Okay, moving in now to the tube light controls. Just down here, we have these green buttons here. What this does is, if I press the green button here to the right, it will switch off the light for the right tube, which means what I'm doing is I'm directing the patient's fixation to the image of the left eye. And if I press down on this green button, the light source will turn off for the left eye, and I'll force the patient to fix with the right. So what I'm doing here is I am able to direct the patient's fixation as I'd like to. And what this also means is that I can perform a cover test, or a type of cover test, on this particular instrument. So when I switch off, say for instance, the left eye, or the light of the left eye, essentially I'm introducing a cover. And so what I'm looking at is whether the right eye takes up fixation. Does it turn out to take up fixation? Does it turn in to take up fixation? And last thing is, here we have these dials that I've labelled as being able to rotate the tubes vertically. What that means is these tubes can be moved up or down. Now this is different to what I mentioned earlier about the vertical deviation control. The vertical deviation control measures the size of the vertical deviation. This lever, on the other hand, makes the patient's eyes move down, which means you assess the patient in down gaze when you do that. Or when you move the tubes up, you're assessing the patient's deviation in up gaze. Now, for the purposes of this subject, we're not going to be using this feature. This is something we'll learn more about in incompetent strabismus, when the deviation alters dependent on direction of gaze. For now, for concomitant strabismus, we will perform all testing in primary position, in which case we will not rotate the tubes up or down, or left or right, or into any tertiary positions. So this is an added feature of the Synoptophore, but not something that we're going to do this semester. At this point in time, I want you to familiarise yourself in terms of measuring horizontal deviations using the horizontal lever and vertical deviations using the vertical dial here. Let's take a look from an angle that gives us the perspective of the patient as well. And what we can see here is the patient is resting on the chin rest, and we can see their forehead up against the forehead rest. And you want your patient to be up against this forehead rest to keep them stable during testing. Now, you'll also want to manipulate this chin rest so that the patient's eyes are looking directly in the centre of the tubes. And if we go back to the diagram earlier, this lever here controls the chin rest. It will raise it and lower it depending on the patient's needs. Okay, I've also indicated here that you have an eyepiece and lens holder. You can actually put trial frame lenses in there. Generally, if a patient has a refractive error and you want to perform the test with correction, then it's perfectly fine for the patient to use their glasses. You don't actually have to use the lens holder. However, if you want to manipulate accommodation, for instance, you could put in lenses within that lens holder. And finally, one more thing. Here is the slide ejector. Now, once you put the slide into the tube, in order to get it out, what you do is you press on that slide ejector and it will raise that slide so that you can actually remove it. And here is an overview of the Synoptophore, where we can see that what we're doing to the patient is we're presenting one image via one tube to one eye, here the line in front of the left eye, the cage in front of the right eye, and then we're asking the patient to tell us what they see, and in this instance they see a lion in a cage. The lion from the left eye and the cage from the right eye. But the pairs of slides we have differ depending on which grade of binocular single vision we're assessing. And this image here shows us this. So we've got the Synoptophore here, and we have a different type of slide for simultaneous perception, different pair of slides for fusion, and different pairs of slides for stereopsis. I'll talk about these more in one of the subsequent videos. Okay, a couple more things about the Synoptophore before we conclude. One is that the Synoptophore is designed to optically simulate infinity or a distance assessment. So when you place a patient on the Synoptophore and you are assessing, for instance, their angle of deviation, it is most closely related to the assessment you performed in the distance. Now, when you go on the Synoptophore in the prac room, you will notice that whilst it is simulating distance, there is a sense of nearness that you appreciate because you're looking through these tubes and those images aren't that far away. So whilst optically it's being induced by using +6.5 lenses which require the patient to relax their accommodation and simulate distance, there is a sense of nearness that can contaminate your results, which means that they may not correlate exactly to what you found in free space in the distance. Nevertheless, the principle is that the Synoptophore is assessing you in the distance. Okay, and finally, in terms of the slides, they come in various sizes. And you'll see here I've listed, you have foveal slides, macular slides, paramacular slides, and peripheral. And they become larger as you move into the periphery. And here is an example of peripheral slides versus foveal slides. And so you can see it's the same, it's a line in a cage, but the size is different. And so if you're using foveal slides, you're really projecting the image only on fovea. So generally I would encourage you, if the visual acuity is good, to always commence with foveal slides and then move up to larger slides if required. Okay, that brings us to the conclusion of this video. Thank you for watching.